This is Dr. Paul Bryman. I'm with the Rowan Virtua School of Osteopathic Medicine in Stratford, New Jersey. I'm an internal medicine physician who practices geriatric medicine and hospice palliative medicine. I'm part of the New Jersey Institute for Successful Aging and full-time faculty at Rowan. Today I'd like to talk about medical aid in dying, which is legal in the state of New Jersey and has been legal in New Jersey since 2019. At the end of life, what we do and how we proceed is an individual choice, whether to receive aggressive medical care or comfort and hospice care, palliative care, is an individual's right and an individual's choice. If you could write a biography, and if life was a book, the last chapter counts. As a hospice medical director for over 20 years, I've had the honor of caring for thousands of people at the end of their life. And every single person has a story to tell, and every single family has cherished memories. New Jersey, however, stands out among other states in how we die. We are number one in the United States in patients who die in the ICU, and number one in the United States in the number of ICU days, number of hospital days that dying people have, by a factor of 20 to 1 compared to some other states. In the Dartmouth Atlas of Healthcare, the latest data is from 2017, and the New York, New Jersey metropolitan area you see over here has among the highest hospital and ICU utilization in the last days of life. The hospice philosophy is to treat symptoms aggressively and not try to make people die faster or slower. In individuals on hospice, there are instances where we need to resort to palliative sedation. Palliative sedation is the practice where in the ICU, in the hospital, at home, people are given medications like Ativan and morphine and Haldol so as to allow them to die in their sleep. The goal is to allow them to have a comfortable death and be asleep when that occurs, and not in pain or gasping for breath. The ethical principle of double effect applies here, where our intention is for the patient to have less pain and suffering, and this may also hasten death, but our aim is not to accelerate the dying process. Palliative sedation has been practiced in hospice care for decades, and it is an acceptable part of the standard of care. So I ask you, what's a good death? If asked, most people would say to die in my sleep, to die at home, not in a hospital or in a nursing home, to have my family with me, and to have a chance to say goodbye to those I love. Most people would choose to be free of pain and to be treated with respect and dignity. To define medical aid in dying, it is a medical practice that enables a terminally ill patient who is mentally capable and competent and an adult with a prognosis of less than 6 months to request a prescription from a physician for medication that they can self-administer, self-ingest, to allow them to die peacefully in their sleep. The type of person who chooses MAID is a very particular personality type. They're individuals who do not want to lose control, want to maintain their independence, want to enjoy meaningful activities, and avoid disease-related suffering like pain, shortness of breath, nausea. They're individuals who fear future suffering. They tend to be resolute, people who are fiercely independent and remain in control of their life and control of their death. Typically, medical aid in dying is not chosen for pain control. Hospice is very good at this. It's more to maintain dignity at the end of life. The stories I hear people tell me are that they don't want to be incontinent, they don't want to be in diapers, they don't want to be suffering, and often don't want to put their families through watching that. Some people confuse medical aid in dying with assisted suicide, and I'd like to talk a little bit about that. Medical aid in dying is not physician-assisted suicide or euthanasia, but unfortunately people confuse the two terms. Medical aid in dying are people who are already dying. In fact, we do have people that we've seen who choose medical aid in dying, but die before they have a chance to ingest the medication. Prognosis in medical aid in dying is less than 6 months and often much, much less. These people are not choosing to die. They have a disease that will cause their death. They're choosing the time of their death. They're not choosing to prolong a painful dying process. Individuals have to be mentally capable and have to be certified by healthcare professionals as being mentally competent. They have a chance to say goodbye to their family. We've seen patients who have goodbye parties, and generally it's not done in secret. Patients, in our experience, are typically surrounded by their loved ones. In suicide, there is no terminal illness. The choice is between living and dying. These are people who may not already, and usually not already dying. It's often impulsive and often, unfortunately, violent. And it happens alone and is associated with mental illness. And it's often very traumatizing to a person's family and caregivers. So when I talk to patients who are choosing MAID, it's very clear that they'd like nothing better than to be healthy and not be dying, but they're dying and choosing the time of their death. It's very different than suicide. Medical aid in dying is legal in 11 states. California, Colorado, DC, Hawaii, Maine, Montana, New Jersey, Oregon, Vermont, Washington State, and New Mexico. MAID's been in effect for 26 years in the United States in the state of Oregon. The laws are pending for several other states, including New York and Massachusetts. The number of people who choose medical aid in dying is relatively low compared to the number of people who die. For New Jersey, during the first year that MAID was legal, about 45 or so people chose MAID. The numbers are typically in New Jersey less than 100 or 200 people a year at the most. And it's important to note that in Oregon, over a period of 23 years, individuals who died by MAID is only 1,900 people. The eligibility for medical aid in dying is 18 years or older, being a current resident of the state of New Jersey, and people need to prove residency by showing you either a driver's license, a voter registration card, or some equivalent ID. They need to be terminally ill with a life expectancy of less than 6 months, and that needs to be certified by 2 physicians, the attending physician and a consulting physician, both of whom must review the medical records. Mentally capable patients only are able to make this decision for themselves, and they have to be free of coercion. The attending physician and the consulting physician both must certify the patient as being free of coercion. And they have to be physically capable of taking the medications. The patients cannot have the medications administered to them. That would be considered euthanasia, not medical aid in dying. So they need to be capable of ingesting the medications by themselves. Examples of terminal illness are most commonly seen in MAID are metastatic cancer, ALS, advanced heart disease, advanced lung disease. We've seen patients with various neuromuscular diseases and Parkinson's disease. People with Alzheimer's disease and other advanced forms of dementia are not eligible for medical aid in dying because they're not mentally competent to make the decision on their own. Important caveats in medical aid in dying are that the death certificate does not list MAID, but the underlying cause of death is recorded as the terminal illness. Life insurance under New Jersey state law may not be affected by medical aid in dying, and insurance does not cover the cost of medical aid in dying or the prescription drugs. The cost is about $900, $750 to $900 range. The patients must ingest the aid in dying medications in the state of New Jersey. In states where MAID is not legal, like our neighboring states, Pennsylvania, New York, and Delaware, the patients may not ingest the medication in those states, and anyone present, if they ingest the medication in New York, Pennsylvania, Delaware, or any of the neighboring states, could be charged with manslaughter. There are, by the way, states that have gotten rid of their residency requirements. New Jersey is not one of them. Oregon has gotten rid of it, and I believe recently Vermont has challenged their residency requirement as well. The process in the state of New Jersey, once a patient is deemed eligible, is the attending physician takes the patient's first verbal request. When the patient requests medical aid in dying, I strongly recommend you document it in the medical record on that day. And the clock starts ticking on that day. A minimum of 15 days must elapse between the first and second request. There are several states who have eliminated or abbreviated the 15-day waiting period. But in New Jersey, a minimum of 15 days must elapse between the first and second request. Only a physician may take the first and second verbal requests. The patient must sign the New Jersey request to end my life in a dignified and humane manner form that is available on the New Jersey Department of Health website. You can find that by looking up New Jersey made Department of Health, and that page will come right up for you with copies of that form. That form is filled out by the patient and needs to be signed by 2 witnesses, one of whom may be a family member, and the other person has to be unrelated and have no financial interest in the patient's estate. Additional responsibilities of the attending physician are that they have to discuss with the patient options, including but not limited to comfort care, hospice care, palliative care, and pain control. The majority of patients in the United States and in New Jersey, over 90%, are on hospice at the time that their request made. We strongly recommend patients be on hospice first, and we strongly recommend that their symptoms be under control before participating in medical aid in dying. But it is not a requirement, but we do recommend that. Prior to making the second request, a consulting physician evaluation is required. This is a second independent clinician who can be the patient's own physician if the primary physician providing medical aid in dying is not the attending. They must be able to confirm the diagnosis, the prognosis, and mental competence, and then complete the New Jersey Department of Health Consulting Physician Form, again available on the New Jersey Department of Health website. Both physicians must document that the patient is competent to make this decision and that they are not being coerced. The patient can rescind the request at any time. They can choose to take the medication or not up to the time that they begin to ingest the medication. If either physician feels that the patient is not mentally competent, they are required to refer the patient to a mental health professional who can be a psychiatrist, a psychologist, or an LCSW to assist in determining the patient's mental capacity and ability to participate in MAID, and they too need to complete a New Jersey Department of Health form available on the New Jersey Department of Health website. Before the prescriptions are dispensed for medical aid in dying, at least 48 hours must elapse between written requests and obtaining the prescription. Once all the requirements are met, the physician can can submit the prescriptions to the pharmacies. We usually recommend that the pharmacy holds the prescription until the patient is ready to use them. In fact, the patient can get the medications at any time they choose. And it's important to know that nationally, up to a third of people don't take the medications, but just knowing that they have them is enough control for them. And as long as they're comfortable, they don't feel the need to take the medication. Others, however, are much more resolute, pick a date that they plan to take the medication, and are not holding on to the medication for very long. Issues regarding storage of the medications in the home are discussed with the patient and the family in detail, making sure that they're away from pets, children, other people who live in the house is vitally important and part of the physician's responsibility, I believe, in making sure that medications are stored safely. The formula, so to speak, the recipe for medical aid in dying is as follows. These are medications that are given by a compounding pharmacy in powdered form. They're not dispensed as tablets. They're dispensed as powders that need to be mixed with liquid prior to ingesting. Morphine 15 grams, 1,500 milligrams. Diazepam 1,000 milligrams, 1 gram. Phenobarbital 5 grams. Digoxin 100 milligrams. Amitriptyline 8 grams. These medications are preceded by an hour by taking Zofran 8 milligrams and Reglan 20 milligrams in order to ensure that the patient doesn't vomit. Patients are instructed to not ingest any food or milk products, anything other than clear liquids, after the evening of the day before ingesting the medication. Any food in the stomach can slow the absorption of medications or interfere with the absorption of medications and interfere with the time to death after ingestion. Most people die within 2 hours of ingesting the medications, about 90% of the time. There are certain outliers. We've seen people take hours longer. Often it's associated with abnormalities of the GI tract or people who have ingested food prior to the ingestion of the medications for medical aid in dying. There are many of us who feel that having a trained professional at the death to monitor, assist, and reassure the family is helpful. This, however, is not required in any state, but it's often very helpful and reassuring to the family when things don't go well. I've had examples of patients not complete ingesting all the medications, where the family was very concerned. We've had instances where people have had emesis, and so having a trained professional at the bedside is often very helpful. There are many roadblocks and challenges to medical aid in dying. Finding an attending and consulting physician is often challenging. In our experience, speaking with attending physicians about their patients requesting aid in dying, we often find physicians who are not aware that medical aid in dying is even legal in New Jersey and are unwilling to participate. Locating a compounding pharmacy is sometimes difficult. There are only 3 in New Jersey where you can obtain medications in powdered form. And so sometimes travel to a pharmacy is difficult. Finding an experienced healthcare provider who can walk the patient through the entire process is very important, and be able to follow up with the family who have any questions. The pharmacist typically dispenses the medications with detailed instructions, but it's important that the attending physician be able to explain the process step by step in detail, since it does involve mixing the powders with liquids and ingesting them. Special situations and red flag situations include patients with difficulty swallowing, which is present in advanced neurologic disease and certain malignancies that involve GI obstruction, patients with PEG tubes, patients with colostomies, and patients who are unable to swallow and require rectal administration of the medications. For individuals who are unable to swallow and mentally competent, for example, individuals with upper GI malignancies or metastatic malignancies involving obstruction of the upper GI system, the insertion of a Foley catheter into the rectum with an inflated balloon is an option for patients to self-administer the medications using a piston syringe. The medications preloaded into the syringe, and the patient simply pushes down on the syringe to administer the medications. In our experience, the effect is identical to taking the medications orally and is safe and effective if done properly under proper medical supervision. It's important that rectal administration of the medication is preceded by an enema and or suppositories the day before to clear the rectum and colon. No healthcare provider is ever forced to participate in MAID under New Jersey law. No pharmacist is ever forced to participate in MAID, again, same as medical professionals under New Jersey law. The patient's physician, however, must release medical records upon request. This is settled case law in every state and is settled case law in New Jersey. I was in the New Jersey Superior Court when the medical aid in dying law was challenged, and that challenge was dismissed. Part of that challenge in the state of New Jersey was about physician releasing medical records, and it is settled law in New Jersey that physicians are required to release medical records upon request for any reason, not just MAID. What is physician's liability? In 26 years, there's been only one lawsuit filed surrounding medical aid in dying, and that was a suit accusing the family physician of refusing to forward the patient's medical record because the patient was requesting MAID. The physician refused to release the records based on their orthodox case. Parenthetically, the challenge to the New Jersey medical aid in dying law was the same thing. And as I said earlier, that challenge to New Jersey's MAID law was dismissed, and it's clear that you need to release medical records. They do not belong to the physician, they belong to the patient, and they have a right to their records for whatever reason. So, what can go wrong? The law does not require the medical provider to be present on the day of MAID. However, this can be burdensome to the family. Often, hospice providers participate. Oftentimes they do not, however, and there are some hospice programs who do not, under their current policy, allow their providers to participate in medical aid in dying. Again, hospice companies, like individual physicians or other practitioners, are entitled to opt out of participation in medical aid in dying. Medications could be spilled or mixed incorrectly. As I said earlier, detailed instructions are provided by the pharmacy and should be reviewed by the physician with the patient prior to mixing and administration. Patient may vomit some or all of the medication. This is very uncommon, and if the instructions are followed, the patient's GI tract is functioning well, and they proceeded by taking the metoclopramide and the Zofran, the medications are rarely vomited. The medications do have a bitter taste due to the amitriptyline component, and that may cause some people to gag. We recommend having a small amount of lemon sorbet available to get the taste of that out of people's mouths after ingesting the medication, and that's often very helpful. The time of death, like I said, 90% of the time within 2 hours. We simply reassure the family that people may not die and that it may take up to 18, 19, 20 hours. There are extremely, extremely rare cases, less than 1%, that have taken up to 24 hours, but it is not our common experience. Most important thing is that after the medications are ingested, no one has ever woken up, and death is certain 100% of the time, and reassuring the family and the patient of that at times is very important. The patient may appear to the family to be distressed as their breathing changes. People undergo the normal stages of breathing changes in dying, which can include either agonal respirations or Cheyne-Stokes respirations, and so families often need to be reassured that this is a normal part of how we die and that the patient is neither awake nor aware nor suffering as this is occurring. The family, when they're alone, may not know when death occurs. Again, this is very rare. Typically, when the clinician is present, they're pronounced. If the clinician is not present, the family is instructed to call the hospice RN to come to the house and pronounce death. In exceedingly rare circumstances, the family may panic, call 911, and send the patient to the ER. If this happens, and it's extraordinarily rare, it's typically because the family has not been adequately prepared as to what to expect. Again, emphasizing that people need to be trained and instructed in detail as to what to expect after ingesting the medication by the attending physician. Our organization is known as the American Clinicians Academy on Medical Aid in Dying. It's acamade.org. It's a database. We have a database where patients can be referred to our participating MAID provider. The physicians are not identified, nor are their names released directly to the patient, but arrangements are made for the physician and the patient to contact each other. There is physician-to-physician support available. There are 24-hour hotlines available as well for both physicians and pharmacists to obtain support. I was one of the first physicians to participate in MAID in the state of New Jersey in August of 2019. and contacting the physician-to-physician support line was extremely helpful for me at that time, and in locating a pharmacist. And then that pharmacist, who is still one of the pharmacy providers in New Jersey, also contacted the pharmacy support line and received the necessary information that she needed to obtain the medications. So all of this is now been worked out in the state of New Jersey. There are several known providers in New Jersey that are available if you're patients or you contact this site. And if you decide to assist your patients in medical aid in dying, this website can support you in what medications to use and how to obtain appropriate support and further information. The New Jersey Department of Health website, if you look up medical aid in dying NJDOH, you'll see the full text of the MAID Act, as well as the forms that you can directly download for the patient to do the written request, you to do the primary physician request, your consulting physician paperwork, and your mental health professional paperwork to be completed. These forms are then submitted to the New Jersey Department of Health after the patient dies, and it needs to be submitted within 30 days of the patient's death. The website is at the bottom of this slide. I hope that this presentation was helpful in explaining the process of medical aid in dying and the importance and primacy of autonomy and patient self-determination in choosing their own death and the time of their death. Again, I thank you very much for listening.